Was he?
And they say, I can tell you, the part of Apollo is a choice.
Good morning. Did y'all get a chance to look over that re-recorded PowerPoint?
Yes.
Some.
Yes, it was very helpful.
Okay, good. Good. All right. So we're still missing several people, but we'll go ahead and get started. So just talking again a little bit about your different fluid volume deficits. When I share my screen, can y'all see that I have your faces pulled up on the side, or is that different for?
No, we can't.
Yeah, I can.
Okay. I can see like 4 or 5 people. I didn't know if y'all could see that or if I needed to move that so that y'all could see the whole PowerPoint.
Yeah.
Okay. All right. So remember we talked about the different types of fluid volume deficit. And thankfully it is the doctor's responsibility to figure out which one of these types of deficits they have and order those appropriate fluids to treat it. But of course, we want to make sure we're given the right thing. I forgot to hit record. And let me mute everybody. Okay. All right, so when we're talking about fluid volume deficit, that means that you do not have enough fluid. So with that isotonic dehydration, that means that you have a total loss of fluid volume. So the amount of blood or fluid that you have circulating within your system is decreased as a whole. So that is why your cells stay the same shape, because you're losing fluid or water and sodium, which is your primary electrolyte in fluid. It's all leaving you at the same time. Okay, so that's why your cells are going to stay the same. And you're going to see that that's your typical dehydration when you think of it. If you've had diarrhea for a couple days, you've been throwing up for a couple days, or if you have like a trauma or a massive hemorrhage, you're losing everything all at once, okay? So then with your hypertonic, that's when you have more salt. You have more salt in the outer portion of the, it's outside the cell, and it sucks all that excess fluid that the cell should have in it. It sucks all that fluid out and makes that cell shrivel up. Because there's a little saying that water follows salt, or water follows sodium. So wherever your concentration of salt is, your water or your fluid is going to follow that direction. So with hypertonic, you have more salt or sodium outside of the cell, and it's sucking all that fluid out of the cell, making it shrink. So that's why you have that cellular dehydration. And then with hypotonic, that is opposite. There's more salt inside the cell. So all that water that's outside the cell is now being sucked up into the cell, making it swell. Okay. All right. So we talked about your risk factors where your infants and young children, their kidneys aren't working quite right, yet they're not mature enough. They also have a greater body surface area. So they're going to be more at risk for becoming dehydrated more quickly than your average adult. The same with adults. Adults are, or the elderly rather, the elderly, their body doesn't make up as, their body weight doesn't make up as much with water. There's not as much water in their system. So when they lose, it affects them more because they don't have the same amount that we would have anyway. Then when your acute illnesses, so you've got nausea, vomiting, diarrhea, you're losing those fluids, so you've got something acute going on. Your chronic illnesses like your liver disease or renal disease and your diabetes. Those environmental factors like being super hot outside and you're sweating and losing a lot of fluid that way. Your diet and lifestyle, if you're not taking in enough fluids, or if you are exercising like crazy and you're sweating and you're really diaphoretic and losing fluid that way. And then your medications, anything that makes you lose fluid, like your diuretics or your laxatives, those are going to make you lose body fluids. And then chemo, again, can make you vomit. They've kind of come a long ways with chemo and giving you lots of medications to try and prevent you from throwing up constantly from it, but you can lose fluids that way. All right. My slides are out of order. Hang on. Is there not one? Do y'all not have a slide that says assessment? There it is. I just couldn't find it. Okay. All right. So when we're assessing a patient with fluid volume deficit, I want to opinion. Okay. Let me go here. All right. So assessment. If I can get this to work. Here we go. All right. So assessment with fluid volume deficit. All right, so what are we going to see in this patient that is dehydrated?
They're thirsty.
Thirsty.
A lot.
Okay, so think about when you're out in the heat and you've been sweating, you get thirsty, right? That's your normal body's mechanism telling you, I'm dehydrated, I need some fluids, okay? But keep in mind that thirst can also be very unreliable. Your elderly tend to not get thirsty. And elderly, they have a normal decrease in their thirst mechanism to begin with. So they don't recognize that they're thirsty. So that's going to put them at greater risk for being dehydrated, right? So that one is unreliable in the elderly. It's also unreliable in infants, because infants can't tell you they're thirsty, right? They don't have the communication skills to be able to tell you that they're thirsty. So we might also see,
like decreased elasticity in the skin, so like their skin turgor.
Yep, we will. I will go ahead and put that one up here. So we're going to have decreased skin turgor, except that one is also going to be unreliable in your elderly, in your infants. So you might have decreased skin turgor in someone, our age. However, think of the elasticity of the elderly. When you pinch their skin up, it tints almost automatically, right? Just because they've lost that elasticity. And their skin's just going to stay like that and go slow to return back to normal. Then with infants, infants are all squishy and juicy. You pinch them up, and even if they are dehydrated, it's going to snap right back because they've got all that baby goodness. They've got all that fluid and fat. So it's not going to really display any kind of decreased skin turgor with infants. But in your normal average adult, sure, you can see that.
Decrease in urine.
Yep, decrease in urine. And it's going to be more concentrated, right? When you get up in the morning and you haven't drank all night, your urine is more yellow, right? So if you have a decrease in your fluid volume, you're going to have that darker, more concentrated urine, and you're going to have a decreased urine output. Output decreased. And with that, in your average adult, you should have a minimum of 30 mLs per hour of urine output. Okay. If you do not have at least 30 mLs an hour of urine that you're seeing on a patient, you need to contact the doctor because these people are severely dehydrated. Okay. That is the minimum where your body has to be able to get rid of that much urine in order to not have your toxins and your waste just start building up in your system. Okay. Then we may have decreased tearing. So your little babies, if they're crying and not making tears, that's going to be a sign that they are dehydrated. Also having a dry tongue or mucous membranes. That's going to be present in all ages. In children less than 18 months, you're going to see sunken fontanelles. And sunken eyeballs. So that area around their eyes, that periorbital area, they're just going to kind of look dark and sunken in when they don't have appropriate fluid volume. And then those little fontanelles on top of their head, if you run your hand across their head, it might kind of dip in more than usual. You may see flat neck veins because you don't have enough volume to fluff that jugular vein up enough. You are going to see orthostatic hypotension. So that is when you stand up, your blood pressure is going to drop, right? So BP drops with standing. Then you're going to have signs of decreased cardiac output. So you don't have enough fluid volume to have adequate cardiac perfusion and have enough blood circulating through your system to really work. So you're going to have those signs of decreased cardiac output. So those are going to be things like fatigue, confusion, decreased level of consciousness. You're going to see hypotension because you don't have enough fluid or blood pumping through your system. So your blood pressure is going to be low. However, you're going to be tachycardic. Anybody know why?
Because your heart is trying to compensate for the decrease in blood.
Absolutely. So your heart starts to beat more and faster because it is trying to compensate and raise that blood pressure back up. So it's working extra hard at trying to keep that blood pressure up. You may also see a weak or thready pulse. Also, if they don't have enough blood volume circulating around, they might be short of breath or have hypoxemia. So they don't have enough blood or hemoglobin to carry that oxygen through their system. So they're going to show that signs of shortness of breath. And that's going to change their mental status as well if they're not getting enough oxygen carried through their system. So I said earlier that thirst and skin turgor are not very reliable in your elderly. So your most reliable thing for them is mental status changes. This is the most common and it's the first sign. Mental status changes. Those are going to be your first sign you see in elderly. So if you have little old grandma who's been completely normal and with it, and all of a sudden she's just not acting quite right and kind of confused and a little disoriented, doesn't know where she's at, I'm going to think first, okay, she's not getting enough oxygen. So her brain's not getting the oxygen it needs. And I'm going to think, well, maybe she doesn't have enough blood or hemoglobin or fluid in her system to carry that oxygen to her brain. So it's going to make her more confused and lethargic. Okay. And then changes in your daily weight. So patients that come in dehydrated or overhydrated, you're going to want to do daily weights on them, because those are going to be your best indicators for any kind of fluid losses or gains. So it's going to tell you right away if they've lost a pound or two or if they've gained a pound or two. Okay. And I think I actually have y'all a handout somewhere too that has some more assessment findings for dehydration. So next, let's look at your diagnostics. So that's the next slide. And I think instead of just switching back and forth, because y'all don't see diagnostics, y'all still see the whiteboard, right? I'm going to, oops, my whiteboard disappeared. Hang on. There we go. All right. So what kind of diagnostics are we going to look at with the patient with dehydration? We are going to look at our hematocrit. And our hematocrit is going to be increased, okay? Unless it's due to hemorrhage. If it's due to hemorrhage, then you're just losing total blood. So you're going to have low counts of any of your red blood cells. But if it's not from massive blood loss and it's just loss of fluid volume, you're going to see that hematocrit increased. And that is due to hemoconcentration. So all that hematocrit, or all that blood, it doesn't have enough fluid volume to dilute it. So it's going to look like there's a whole lot more blood in comparison to your fluid volume.
So it's going to have increased viscosity.
Probably. You're also going to have an increased BUN. So your BUN and your creatinine, if you don't have enough fluids to flush out your kidneys, it's going to show that in your BUN and creatinine. Urine specific gravity is also going to be increased. So that's because your kidneys are trying to conserve and hold on to any water to keep what fluid it does have. So it's going to hold on to that water, but it's going to try and get rid of any excess solutes. So like excess sodium, it's going to try to get rid of. And then your sodium level is also going to be increased. And that's just because of your sodium level, or your sodium being concentrated as well. So when you're dehydrated, if you notice, all your levels here are going to be up. Okay, and they're all going to be raised levels because you don't have enough fluid volume. So everything's concentrated. Okay. All right, so next we'll look at our different interventions for dehydration. All right, so interventions for fluid deficit. All right, so the first thing we can give them is oral replacement therapy. And that's going to be things like your Pedialyte or your Gatorades. Okay. Your average adult should take in average adult should take between 60 and 120 mLs an hour of fluid. Okay. So we want to make sure that they are taking in this much, or they're at risk for becoming dehydrated. So we're going to start and offer them this oral replacement therapy, that Pedialyte and that Gatorade. Okay. With these, they are made in such a way that even if you do have diarrhea, or even if you're throwing up, the electrolytes in these get absorbed really quickly. So that's why it's still going to be beneficial, even if you're throwing up or having diarrhea. Okay. But with offering those oral replacement therapies, you have to make sure that it's only going to be effective if you have a mild deficit. So if you're super crazy dehydrated, drinking some Gatorade is not going to help you. So you should have a mild deficit. Your thirst should be intact. And you need to make sure that your patient can drink. If they have swallowing trouble, or they're completely out of it and it's not safe for them to take POs, then you're not going to offer them those PO fluids. With infants and young children, you can offer them like a few teaspoons every few minutes. So with those little babies and little toddlers, you don't want to have them just start gulping away at their Pedialyte. They don't feel good. If you just have them chug, 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 they're more likely to just throw it right back up. So you just want to offer them a few little sips here and there every couple of minutes. Also keep in mind that freezer pops are also good. So freeze that Gatorade or freeze that Pedialyte. It can help them, you know, they don't feel good. It might perk them up a little bit. They might be more keen on eating that little popsicle treat than drinking out of a sippy cup. So that's something you can offer them. You do want to start out with those Pedialytes or Gatorades. You do not want to give them any kind of formula or lactose products. Oh, they make Pedialyte pops now. Cool. There you go. All right. So no formula, no lactose-based fluid. So we're going to stick with these electrolyte-based replacement fluids. With any age, you initially want to avoid any kind of sugary drinks, like avoid fruit juices or sodas as their fluid replacement, because these tend to have a very high sugar content, and taking in all those excess sugars are going to increase diarrhea. So you don't want to give them those apple juices or grape juices. We also want to avoid salty drinks, because that is also going to lead to diarrhea. We're also going to avoid caffeine. Why are we going to avoid caffeine?
Diuretic.
It's a diuretic, so it's going to make us lose urine. So what are we going to encourage these people to eat? They can have their Pedialyte and their Gatorade, but we want them to try and eat too, right? So how many of you have heard of the BRAT diet? So BRAT diet stands for bananas, applesauce, bananas, rice, if I can go in order here, applesauce, and toast. Okay, these are all very bland foods, and they have been proven to shorten the duration of any kind of gastroenteritis or GI bugs. Okay. So if they can tolerate and keep things down, we're going to offer them that BRAT diet. Any questions up to this point before I get into the fluid treatment, because it can get confusing? Nope. All right. All right. So we have our fluid volume deficit. And we are going to say they are super dehydrated and they're not able to hold any kind of POs down. They're not able to take any of the Gatorade or whatnot. So we're going to have to give them IV fluids. Okay. So if we have our isotonic dehydration, remember that's just our circulating volume, fluid volume. It has been depleted. So nothing has changed with our actual cells because we're losing everything equally. So what we're going to do for these patients that have that equal fluid loss is we are going to treat them with isotonic fluids. Makes sense, right? All right, so we're going to give them things like sodium chloride at 0.9%, okay? Or it can be put down as NS, normal saline, okay? So So these are all the same thing right here. This is normal saline. All right. So what this is going to do is we're going to give fluid boluses. We're just going to replace, I cannot write fluid bolus, to replace lost fluid. If it's due to hemorrhage, we're going to give blood transfusions. Hemorrhage. So that makes sense, right? If you are stabbed and you are losing blood profusely, then you're going to want blood products to replace and bring that fluid volume back up. But if you just have lost fluid because of diarrhea or not taking in enough fluids or throwing up, we're going to bolus you with that normal saline. And bolus means that you have your whole liter bag, and I'm just going to open it wide up and let it fly in. Okay, I'm not going to run it at some kind of slow setting. I want it to get in and help right away. Okay, so we're going to give that fluid. Why does that keep doing that? It keeps wanting to put an extra text box, and I don't want it to do that. All right, so we're going to give that fluid bolus until we achieve that adequate fluid volume or circulating blood volume. So that's going to help our cardiac perfusion, and that's going to help our renal perfusion, because we're going to boost up all those all that fluid that we've lost. We're going to replace it so all of our organs can start working again properly. Okay. So another isotonic solution you can use is called LR, or lactated ringers. This is actually getting more and more used. Normal saline has always been our golden standard, but they have found with recent studies that lactated ringers actually tends to help a little bit more. However, the problem with lactated ringers is if you want to give anything with it, like antibiotics or other medications, tons and tons and tons of things are not compatible with LR. So you have to be super careful. So that is why it is so much more easier for them to order normal saline, because it's pretty compatible with everything. Okay, but do know that your LR is considered an isotonic fluid.
Miss White?
Yes.
What is the base of the lactate ringer? Like, I know the normal saline is sodium. Like, what is in lactate ringer?
LR has different percentages of different electrolytes, and I don't even know exactly what the percentages are, but it has a few more solutes in it. Though you'll most often see LR in your post-surgical patients.
Yeah, because we use it a lot on my floor, so I was just wondering.
Yeah, it's got a little bit more electrolytes than just your normal saline.
Okay.
But nurses hate it because it doesn't mix with much of anything. All right. I do want to comment to make sure that everybody is well aware of this. So when you look at your charts and graphs and everything, it is going to list D5W as an isotonic fluid. Okay. Isotonic fluid. However, it is only considered isotonic when it's sitting in the bag and when you immediately infuse it. Once it is metabolized, so within minutes, once metabolized, it turns into a hypotonic solution. Okay. And we'll talk about hypotonic solutions here in just a sec. Okay. So you're going to see D5W listed as isotonic on your charts, but we're not going to give that because we're going to treat it like it's a hypotonic solution, because as soon as it's metabolized, that's what it's going to be. Okay. Oh, does that not highlight? I wanted to highlight. Go away. Okay. All right. So does everybody have isotonic dehydration? Or, yeah. So true isotonic fluids are normal saline, LR, and blood transfusions. Yes. And just as a side note, the only fluid that you can give with blood transfusions is normal saline. So you don't ever want to give blood transfusions with anything other than normal saline. All right. So then let's move on to our hypotonic fluid volume deficit. Okay, so with our hypotonic, actually, let's go to hypertonic dehydration first. Hypertonic fluid volume deficit. All right, so remember in hypertonic fluid volume deficit, this is our cellular dehydration. Okay, so our cells are shrunken. Okay. And I seriously can't type. All right, so hypertonic cellular dehydration, our cells are all shriveled up. So we need to figure out how to get fluid back into that cell to rehydrate it, okay? So we are going to give them hypotonic IV solutions, okay? So we're going to give them the opposite. So what those hypotonic solutions do is it's going to draw your fluid into the cell to rehydrate it. Okay, so it's going to make those cells swell and puff up back to normal level is where we are hoping for, right? So your common hypotonic solutions are going to be things like half normal saline, or I'm trying to write down all the ways that it can be written. Sodium chloride. Okay. And that is half normal saline. So that is a hypotonic solution that's going to draw fluid into the cell to rehydrate it. Okay.
Miss White?
Yes.
So on this paper, it says it's sodium replacement, not for fluid replacement. So would you still give fluids like normal saline with the sodium or like PO fluids?
Yeah, you can.
Okay.
Yeah, you can always, if they're able to tolerate POs, you can give them, you know, PO fluids along with their IV fluids.
Okay.
Is that what you're asking?
Kinda. So it's sorry, I'm losing my voice. But the 0.45 sodium chloride, it said under uses, it said sodium replacement, not for fluid replacement, especially renal function.
Mm-hmm.
So whenever you give the 0.45 normal normal saline, would you give something else with it?
Not typically. Like
Okay.
IV wise, no.
Yeah. Okay.
All right. So we have our half normal saline. So think about what this is doing. So our cell is all shriveled up from being dehydrated. So we're going to give a hypotonic solution to rehydrate it. So what does that put us at risk for?
Fluid overload.
It could
Hypernatremia.
put us at fluid overload.
Yeah.
What else? So if we give lots or overdo it on the hypotonic solution, we can overhydrate that cell. So we could give too much and cause that cell to swell and burst. Okay. So I should be careful. You're going to monitor these patients very closely, because if they get too much and those cells start to swell, I don't know if y'all remember from the other day, what happens when we have those swelling of the cells? They can burst, or remember, our brain cells are super sensitive to any kind of swelling.
You're gonna have confusion.
Absolutely. How do you spell sensitive? Sensitive. That's not right, but you got the gist of it. So your brain cells are super sensitive to that swelling in that cell. So you are going to see confusion if that happens. Because they're going to end up having cerebral edema, which is a bad thing. Okay. All right. So then, is everybody following with me on that one so far?
Mhm.
I'm going to clear this so I have room. All right. So now we have a patient with hypotonic dehydration. Okay. So that is where our cells are already swollen, right? Cells are swollen. So we have less fluid volume outside the cell because it's all inside it, causing it to be swollen. So what do y'all think we should do? We need to shrink those cells back to normal size, right?
Give them hypertonic.
So we're going to give hypertonic solutions. Hypertonic. Because we want to draw that fluid out of the cell and back into that extracellular fluid. Okay. Your common solutions that are hypotonic, Have y'all talked about TPN yet? So TPN is just,
No.
it stands for total parenteral nutrition. So that is somebody who absolutely cannot eat and has to get their nutrition through an IV bag that's going to have their nutrition and their electrolytes in it. Okay. Some other common solutions that are hypotonic or hypertonic solutions, sorry, are going to be D5 normal saline and D10W. So y'all know D stands for dextrose, so sugar water. Okay. There is also 3% and 5% normal saline. These are high alert medications. You will only see that 3% and 5% normal saline in critical care units. Okay. So think if you have a bag of fluid and 3 to 5% of it is salt, what do you think you could do if you overload that patient with this fluid? Garrett, you're on mute. I saw your lips.
They pulled too much fluid out of the cells.
So you're going to have your cells shrink. You've got too much salt, so those cells are going to end up getting dehydrated again, and it's going to suck all that fluid that was in that cell back out. Okay.
I guess I have a question. So as new nurses, we're presented with a patient. We know they have some sort of dehydration. We don't know which one. And some of the signs and symptoms kind of overlap. But I guess we're always in the back of our minds, we have to act. So is there a course of action that is least harmful to the patient, or you just have to wait for your blood tests and your labs?
Your least harmful is going to be your normal saline.
Okay.
Yeah. I have only once in my entire career have I seen that 3 to 5% normal saline. It's not given very often. You're not very often going to see that D5 or D10 either. With your half normal saline, you'll see it a little bit more often, but overall doctors will go on the safer side and administer that normal saline or LR just to replace total fluid volume. And that's just your most commonly given.
Miss White. So I know the D5 is dextrose with normal saline. The D10, what is the D10?
D10 is dextrose 10% in water.
In water, okay.
All right. So it's going to be used, we're going to use hypertonic solutions for our patients that are, have had starvation, may have ETOH or alcohol abuse, or severe sodium depletion, where we really need to replace that salt.
Miss White, did you say D5 water was hyper or hypotonic?
D10W is hypertonic.
What about
D5 is hypotonic.
Okay.
Okay. All right. So your key takeaway here is if it's isotonic dehydration, we're going to treat it with isotonic fluids. Okay. If we have hypertonic dehydration, we're going to give hypotonic solutions. If we have hypotonic dehydration, we're going to give hypertonic solutions. Okay, so you're going to give the opposite because you want that cell to do the opposite of what it's doing. Okay, does that make sense? Hope so. All right. So, what are some other interventions that we're going to do for these patients? Well, we did our initial assessment and they were dehydrated, so they had low blood pressure and high heart rate, right? So now we're bolusing them with fluids. So now hopefully we're going to have some normal vital signs, right? We're going to see that blood pressure come up and that heart rate go down. We're also going to assess their lung sounds, right? Because if we are bolusing these patients 1 liter after another, what are we putting them at risk for?
Aspiration or pneumonia.
Well, we're putting them at risk for fluid overload. We're going to overload, send them into congestive heart failure.
Okay.
So with these patients too, we're going to measure eyes and nose, right? They're having diarrhea. We want to know how many stools they're having. And we're going to monitor how much they're putting out versus how much they're taking in. Because we want to have your gains equal your losses, right? You want that fine balance. And it's going to help you look and see if your kidneys are kicking in and starting to function a little bit better. Because remember, we had decreased urinary output and it was concentrated. So as you start to rehydrate that patient, you're going to see more clearer or straw colored urine, and you're going to hopefully have over 30 mLs an hour, right? That's going to tell you, oh, their kidneys have kicked in and they've started working and they're rehydrated. That's what I want to see. What
Daily
else?
weight.
I didn't hear that. What?
Daily weight.
Daily weight. Yes. We're going to do daily weights to see if they've lost or gained anything. We're going to encourage PO fluids. If they're able to tolerate POs, I want to try and get them off of IVs as soon as I can and have them taking in PO fluids, right? So I would, if they're not ordered in PO, I'm going to offer fluids hourly. You can give them cold stuff, frozen stuff, hot stuff, anything, just to get those fluids in them.
This way.
Yes.
Since we're dealing with electrolytes, wouldn't they be on a cardiac monitor?
It depends on what their potassium is.
And the sodium?
Sometimes, but your potassium is going to be what triggers them to order the telemetry monitor most often. Okay. So it's potential, but just because you're dehydrated, a lot of times they're not going to order telemetry unless you really have some electrolyte imbalances. So they've got dry mouth because they're dehydrated, so we're going to provide mouth and lip care. You can offer, if they are MPO, you can offer those little mouth swabs. They love to chew on those. So if you still have a patient whose blood pressure is still low, we can position them in Trendelenburg. So we're going to put their feet higher than their heart. So that's going to get any of those fluids heading back towards the heart so that we can make sure that that heart is perfused. And that will hopefully get their blood pressure up a little bit. We said daily weight. Of course, fall precautions. Because if you're dehydrated, you might be dizzy. So we want to put them on fall precautions. And remember, we talked about that brat diet. So bananas, rice, applesauce, and toast. We'll also often start with a clear liquid diet and then advance them to like a soft diet and then a regular diet. I've read somewhere that actually yogurt is good for them, but not milk. Yogurt is good, but not. So that will help get something in them. And just really monitor for fluid overload. So that's going to be, listen to their lungs and looking at their like their extremities, their lower legs. Monitor. Seriously, I can't type. Monitor for fluid overload, because that's a big one. Because the doctors will inevitably forget that their patient has a history of congestive heart failure, but they came in dehydrated, and they're just going to order a bolus and then fluids to run at 125 an hour, and you're going to eventually put that patient into overload. So always keep a close eye on that patient.
Well, sometimes the doctors put these patients with LASIK as well.
Yeah, sometimes they will. So you're like a catch-22, and they're fighting each other in the process. Yeah. Sometimes you wonder what. All right. So what other medications can we give? So this patient is dehydrated because they have been throwing up. So what are we going to give? Antiemetics. So that's going to help them to prevent fluid volume loss due to vomiting. And we love to give promethazine, which is Phenergan, Ondansetron, which is Zofran. And our least commonly used ones are Compazine and Kytril, but they work really good. They just don't get used very often. You have that patient that's dehydrated because they have diarrhea. We're going to give antidiarrheals. So we might give loperamide, which is Imodium. We might give them Lomotil. And those are going to help with preventing fluid loss from diarrhea. Let's say they are have diabetes insipidus or SIADH, where your body is putting out massive amounts of urine, which is not a good thing. So you're losing large amounts of urinary volume. So we are going to give antidiuretic hormones. And that's going to be vasopressin. There's only one S in it. Or its generic name is, or its brand name is DDAVP. Then let's say they have a fever and they're not feeling great with that fever and they're just sweating profusely. Antipyretics. So we're going to bring down that fever so that they're not sweating like crazy. And we can do that with Tylenol and Motrin. And did y'all know, it's been out for a couple of years now, but when I first started nursing, it didn't exist. But there is IV Tylenol now. It's called Affirmiv, and they give it very often after surgery. So I thought that was cool. That came about several years ago. That didn't exist when I started nursing. All right, so with those patients with their medication, we're just going to give them stuff to help keep all those fluids inside them and decrease nausea, vomiting, diarrhea, that kind of thing. Okay. No, Maya. So vasopressin is not for diabetes mellitus. It's for something called diabetes insipidus. And I won't go into detail about that because I think Ms. King covers that in the next unit. But diabetes insipidus, there's some kind of hormonal imbalance that makes you put out like 30 liters of urine a day. It's like massive amounts of urine. So that's not normal to put out that much urine. So we would give them that vasopressin to limit and decrease that amount of urine output. Okay. So she'll go over diabetes insipidus and diabetes mellitus and syndrome of inappropriate ADH. All right. What time do we start lecture? 10. So it's 11. So we'll take a 10-minute break and come back. Okay. All their medicines. So we're just going to do a little bit of education for our patients. The first being to prevent that dehydration. So teaching them to eat a healthy diet, eat foods that are high in water content. We do want to teach our elderly to make sure that they're drinking even though they don't feel thirsty. And remember, we can tell them that fluid can be anything that's frozen that unfrozen would normally be in a liquid state. So like popsicles, ice cream, Jell-O, any of those things are going to help replace fluid. Also, we're going to encourage those health buffs to exercise during cooler parts of the day. Don't, go out and exercise in the hottest, sunniest part of the day, and to make sure that they're drinking plenty of water. And it actually recommends 5 to 6 ounces every 15 minutes during exercise. And then we're going to teach them about the Gatorade and Pedialyte to avoid those salty fluids, because that's going to increase our dehydration by promoting diarrhea, as well as sugars. We don't want them to eat lots of sugary or take in lots of sugary drinks, and to avoid that caffeine because of the diuretic effect, and to limit their intake to that brat diet until they get to feeling better. And then if it's due to overusage of diuretics or laxatives, we want to educate them on the proper way to take those medications. So next we will look at hypovolemic shock. And I'm not going to go into great detail on hypovolemic shock just because you'll focus more on that with critical care. But your causes of hypovolemic shock is, of course, hemorrhage. You have this guy over here who's got some kind of wound and he's just massively bleeding out. So you're going to have a very marked decrease in circulating blood volume. So you're going to see that in like traumas or maybe a ruptured ectopic pregnancy. You may see that in placenta previa or placental abruption, where the placenta tears away from where it's supposed to be, and it will cause lots of hemorrhaging. So anything that's going to cause massive generalized fluid volume. Then the things you'll see with that hypovolemic shock is that urine output that is less than 30 mLs an hour. That patient's going to be very lethargic. They may be restless because their brain's not getting enough oxygen. Again, they're going to have a low blood pressure, but their heart rate's going to be up because their heart's trying to get plenty of blood out to the whole body to try and raise that blood pressure and to try and perfuse everything that it needs to. You're going to see that weak pulse. You're going to have that delayed capillary refill time, and you may see that cool, clammy skin. So if you have that patient in hypovolemic shock, you're going to just essentially treat what the cause was. You want to stop that massive bleeding somehow. Hypovolemic shock is life-threatening, if you can believe that. So anytime somebody's, in hypovolemic shock, think of a trauma patient. You're going to follow your ABCs, where we're going to make sure we have an airway. We're going to protect their breathing. We're going to look at their circulation and try and make that bleeding stop. We're going to make sure they definitely have IV access, because we're going to be pouring in blood and fluids like crazy on these people. Okay. And that's actually the next slide. So for right now, all I want you to know is if they're in hypovolemic shock or they have had a trauma and they've got massive fluid or blood loss, we're going to give lots of normal saline or blood transfusion to just replace that fluid in general. Okay. So how many people have seen third spacing? This isn't the best example, but I couldn't find a good one. So third spacing is almost, to me, is a type of swelling and fluid volume overload that when you touch the patient's skin or you see the patient's skin, it's like you can see ripples of water and fluid underneath their skin, and you can just barely touch them, and it's almost like they'll just start seeping and oozing out that fluid. You'll see this a lot in patients that are about to expire if they've had a long death process. You can also see this in liver issues, renal issues. But essentially, third spacing is you end up having increased vascular or increased capillary permeability. So all your capillaries and your blood vessels are essentially leaking fluid out into your interstitial spaces. So you have all of this excess fluid that serves absolutely no purpose. It doesn't function as anything. It's not used as your fluid reserve. It's not used as transporting nutrients. It doesn't help with metabolism. It serves no purpose. It's just excess fluid hanging out in those tissues. And Lasix typically does not help this. Usually you have to give these people with third spacing albumin to help shift that fluid back in the right place. But that's not on the test. So some common places to see that third spacing or that massive excess fluid and swelling are in your tissue spaces. A lot of times it'll be in their arms and like in your sacral area. If they're, bed bound, all that fluid just kind of pools right at their backside. So their hips and their sacral area will be really swollen with that excess fluid. You may see it in your abdomen, especially in patients with liver issues, and that's called ascites. And I've had patients that are so distended and full of fluid in their abdomen that you can kind of smush on their abdomen and you can just see ripples of waves because it's got such massive fluid volume. if you have this excess fluid in your pleural spaces, it's called pleural effusion. And then if it's in your pericardial spaces, it's a pericardial effusion. So those are just kind of excess fluid pockets. Okay. And what causes third spacing? It is typically injury or inflammation that's going to increase that capillary permeability. So you may see it in massive traumas. You may see it in burns. You may see it in that septic patient. And again, in end of life. I always feel so bad for these people. They look miserable that have this third spacing, especially if it's in their arms. You're kind of trying to wrap up their arms in like Chuck's pads just to try and control and contain all the fluid that's leaking out of their skin from all that excess fluid.
Miss White?
Yes.
I've seen third spacing like so bad that their skin is starting to like rip open and they have wounds.
Yep.
It's gross.
It's bad. Once you see it, if you haven't, once you see it, it's like there's no good way for me to even describe what it looks like or what it can look like. You feel bad for these people.
Their skin is really shiny looking.
Yes, very shiny, very, very thin looking. And it's like you can just see water up underneath that skin.
Yeah.
I've looked and looked for pictures of it and I haven't found a good one I like yet, but yeah, it's crazy. You'll never forget that picture when you see it. All right, so we talked about dehydration, third spacing. So now we're going to talk about fluid volume excess. So we are in fluid overload. We've got too much fluid in our circulating blood volume. So the first one we're going to look at, pull my whiteboard back up here. Is isotonic fluid volume excess. Okay. So with that, our extracellular fluid volume increases. But our intracellular, so inside the cell, stays normal. It stays the same. So our cells are completely normal shaped, just exactly like they should be. But for whatever reason, our fluid outside of those cells, there's way too much of it. Okay. So this gives us an increased circulating volume. And this will happen when your body retains water and sodium. In similar proportions. So again, you have the isotonic, meaning equal. Okay. So it gives us increased circulating blood volume, and this is going to lead to tissue edema. So think of your patient with congestive heart failure and how swollen their legs and hands are. They have all that excess fluid in their tissues and it's causing them to swell up. Some causes are going to be things like renal failure, because your kidneys are not excreting the fluid that they should be. You're going to see it in heart failure. Your blood's just kind of hanging out there in your heart and your tissues, and your blood's not being pumped around like it should be. So it's just kind of all sitting there and causing excess fluid. Us as nurses might cause it with excess IV fluids. So this is why we need to carefully monitor our patients that are on IV fluids to make sure that we aren't causing them to go into fluid overload. Those are going to be your most common causes. Okay, so then we have hypotonic fluid volume excess. And this has a fancy name. This is going to be called water intoxication. Okay, so you can kind of gather from that name that we have too much what?
Water.
Water. So water moves into the cell and it causes cell swelling again. Okay. So what happens here is your water ends up diluting your electrolytes in the extracellular or bloodstream. And it causes those fluids to shift out of the extracellular fluid and into the cells. Okay. So some causes for water intoxication is drinking too much water. So imagine you have this patient who has some cognitive impairment, or patients with bipolar or OCD, where they're just drink. That's one of their obsessive traits or characteristics, where they're just drinking too much. You can drink too much water and it ends up screwing up your fluid balance.
Literally my aunt.
Really?
Mm-hmm. Yeah, she was in the hospital, I think like 2 weeks ago, because her OCD and like the little voices in her head, they tell her to drink, and her sodium just tanked.
Yep.
Tanked.
It sure will. It sure will.
I had a patient like that, and she tanked her sodium tanked like that, but she refused. Like, the doctor was like, I can't give you any more water, and she pitched, like, I'm talking about the biggest fit, because the doctor's like, I cannot give you any more water. She's like, you're hurting yourself. And she ended up leaving AMA. She was like, you're not gonna give me water, I'm leaving. So, but yeah, it's crazy.
Yeah, those patients don't like being told that they can't have water, but they don't comprehend that it's physically harming them. So you have to teach them to limit their water, and they're put on free water restrictions, and you have to limit their amount of water. This can also be caused by improperly prepared baby formula. So let's say you have a mom who's trying to extend the use and life of her baby formulas because they're not cheap. So she might dilute it a little too much to try and make more. Well, that's actually going to harm that baby. So we want to make sure that they're not, that they're measuring stuff properly when they're mixing up formulas. If we use plain water for NG tube or bladder irrigations, or if we give too many tap water enemas. So to fix this, if we still need to irrigate their bladder or irrigate their NG tube, we're going to do that using normal saline because it's got some salt in it. So normally you would just use water to do that, or do your tap water enemas with water. But water, like we said, it dilutes everything, or we call it free water. It doesn't have all the electrolytes in it that you need. So we may switch up and have to do normal saline for those irrigations if they end up having this problem. Okay. Then I actually should go back to and add, if we're giving these patients, I don't remember if I said this earlier, if we're giving these patients hypotonic IV fluids, we want to make sure that we're not causing that overload and causing those cells to swell. Because remember, that's going to end up causing some cerebral and brain issues. Somebody had a question. Are there any signs for hypotonic? I don't think that there really are, other than you might have some swelling, and you're going to see it most with your labs. You're going to see like a low sodium level because you've diluted your sodium levels, diluted your blood. Okay. All right. And then to make it easy, there is no such thing as hypertonic fluid volume excess, because that's cellular dehydration. You don't have any excess fluid, so that doesn't exist. Okay. All right. So our risk factors. So your age, of course, is going to be a risk factor. Your elderly patients tend to have decreased heart and kidney function, right? That just comes with age. So they're not able to easily compensate and get rid of any kind of excess fluid volume. Their kidneys aren't top notch, so they're going to have trouble getting that excess fluid out. So it's being retained, causing problems. Same thing with infants. Their kidneys are not completely mature yet, so they're not able to eliminate all that excess fluid and waste. Excessive salt intake can cause, think about your congestive heart failure patients. We don't give them much salt in their diet because anytime you have salt, remember how I said earlier, water follows salt. So if you are taking in massive amounts of salt, any kind of fluid just kind of sticks there and hangs around with that salt. So that's why any kind of cardiac patients will have low sodium diet so that they won't be able to retain that excess fluid. With your acute illnesses, a lot of times surgery can cause swelling. We pump you full of fluids during surgery or during labor. So your body is dealing with that trauma and trying to keep everything regulated, but you may end up retaining some of that fluid that we give you. So it takes a few days typically to try and get rid of some of that swelling. Then Then with chronic illness, like I said earlier, with your kidney disease or your heart disease, your body's not able to get rid of all that excess fluid. So that's going to cause you to have that increase in swelling and problems. And then, of course, the excess fluid, IV fluid infusion, we have caused an overload. So just keeping a close eye and frequently assessing those patients, listening to their lung sounds, looking at their vitals, to making sure that we're not causing their fluid volume overload. Okay. So how are we going to assess for our fluid volume overload? We are going to see, and I'm going to pull up my whiteboard again. Here. Oops. All right, so we have our assessment for fluid volume excess or fluid volume overload. So what's the top number one thing you're going to see?
Edema.
You are absolutely going to see edema. You're going to have those swollen feet. You may have swollen sacral areas if they're bedbound, swelling in their hands. You could have pitting edema or non-pitting edema. Just kind of depends on the patient and what's going on with them. You can actually have edema around your periorbital area, so around your eyes. And edema does tend to follow gravity. So keeping those patients with their feet propped up, that's going to help decrease that swelling. On the slide or on the PowerPoint, there's a really good picture of JVD or jugular vein distension. JVD. So jugular. So that's where that lady, you can see that vessel right there, that jugular vein is really engorged. So that is a clue that they've got too much fluid going on in their system. You're going to see an increased blood pressure. Your body's having to work harder at getting all that excess fluid that you're carrying around. So it's going to make your heart work harder, making your blood pressure go up. You're going to have tachypnea. Oops. And dyspnea. So you're going to be breathing hard and you could potentially be short of breath, right? We have our patient that's in fluid overload. We've given them too much fluid or they have congestive heart failure. They may have an irritated cough or an irritating cough. We have a cough. Have that labored breathing. What kind of lung sounds are you going to hear in a patient that has too much fluid?
Crackles.
Yep, you're going to hear crackles. So it's going to kind of sound like Rice Krispies, or I've had someone say that take your hair and kind of run it between your fingers by your ear, and that's the sound that crackles will make. You're going to have a decreased O2 sat. And a late sign is going to be cyanosis, or them turning blue. That's a bad thing. That means that you haven't assessed in the early stages well enough that they've now progressed to having some very serious breathing problems. And it's gonna be harder to treat those people. You may also see polyuria or frequent urination. So if their kidneys are actually working properly, you're going to see increased fluid volume from their Foley or from them just using the bathroom. Obviously, if they have kidney failure, that's not going to be the case. If they have kidney disease or kidney failure, they're going to have decrease. Output. Okay. These patients, if they're holding on to a whole bunch of fluid, what are we going to do? What are they going to have? We get daily weights on our patients with heart failure because they can gain weight very rapidly. You know, they can gain, 3 to 5 pounds in the course of a day or two. And then we're going to look for changes in level of consciousness, as well as headache or visual disturbances. Because this might tell us what? Cerebral cells are swollen in that hypotonic fluid volume excess. So if they're having visual problems or if they're decreased level of consciousness or headaches, they might be having something going on with their brain, or increased intracranial pressure. So next is your diagnostic studies for fluid volume excess. So what are we going to test? So with fluid volume deficit, where we had hemoconcentration, what do you think if we have too much fluid?
Decrease.
Everything's going to be decreased because we are then hemodiluted. So we're going to have a decreased hematocrit. We're going to have a decreased BUN. We may have chest x-rays done. Your patients that come in complaining of shortness of breath, and we think they might have congestive heart failure, or we hear crackles, we're going to do a chest x-ray on them to confirm that. So a chest x-ray is going to show us any kind of pleural effusions, and it's going to show pulmonary edema. It's going to show us congestive heart failure, any kind of fluid overload that's going on with our lungs or heart. Okay. So then what are some interventions that we're going to do? So if we have a patient.
Miss White.
Yes.
Please, what did you say about the CSL?
Congestive heart failure.
Okay.
So your chest x-ray, if you have a patient that's having shortness of breath and you hear crackles, a lot of times you're going to call the doctor and get a chest x-ray done. And it's going to show that, yes, they have fluid in there. They're in congestive heart failure.
Okay. Thank you.
Yeah. So with that patient, we're going to assess them often. We're going to be checking their respiratory status very often, because these patients are at risk for heart failure from holding on to too much fluid. I already told you that. these patients may be on a fluid restriction. We're going to limit their fluids to 1,000 to 1,500 mLs a day, typically. And they usually hate that, hate it. And also here, this is going to include, you know, if you think about this, a liter of fluid. So Catherine has a liter of fluid hanging back there behind her. I see it. So imagine that that is all the fluid that you can take in a whole entire 24 hours. That's not a lot. So these patients are usually not happy. So that's going to, those fluid restrictions include all 3 meals, any kind of snacks or just drinking water, and any kind of water you give when you're administering medication. So I always used to just take them a little tiny, y'all know, bathroom cups that Dixie puts out. They're just little tiny cups. I would tell them, this is how much water you get to take these pills with. You know, try and drink as little as you can with your medication so that you can save that other fluid that you're allowed for your meals or whatever. So we want to make sure that we're counting all of their fluid. We may also do a sodium restriction. Now, our patients with congestive heart failure, like I said, they get their low sodium diet. If we're doing mild restrictions or they have mild fluid retention, we might allow them to have 4 to 5 grams of sodium a day. I have never seen that. The average of what we limit people to is 2 grams of sodium a day. So you'll see them on a 2-gram sodium diet. So that way they don't retain as much fluid. We're going to provide mouth care. If we're doing mouth care, that hopefully will decrease their thirst triggers. So just keeping their mouth moist, handing them those little mouth swabs will help keep their mouth moist and lessen their craving or desire to actually drink.
It's like some people now, I know on our unit when we're making an NPO, we've been giving them like a gum to chew on a gum if they can, or a mint, because it seems to help them with that irritation of not being able to drink.
Right. That might be very specific to your unit. You're on post-surge, aren't you?
No, cardiac, thoracic, and vascular.
Okay.
So we get a lot of pre-op infos.
Hard candy is crazy hard to find in the hospital.
Oh yeah, we actually provide it, so we have it for them.
Yeah, but yeah, that is a good solution if you have that available. I do want to mention that providing ice chips is allowed if you have a doctor's order, and that's if you have a doctor's order. They'll say NPO accept ice chips, meaning that they can have a few ice chips. But remember that ice chips are a liquid, so they're going to count in your fluid restriction. So I can't remember the measurement, but I think like a whole cup of ice equals a half a cup of water. Is that right? So keep that in mind. It lasts longer, but it's still going to count against them. So just keep that in mind. Also encourage cold fluids, because warmer or hot fluids actually make you thirstier. And then we may also give these patients diuretics to help promote excretion. Okay. This is especially true in patients that have like congestive heart failure. You're going to give them Lasix left and right to try and get them to excrete that fluid. patients with renal issues and those that say you're in renal failure, and those patients don't void. They don't urinate most of the time. So you're not going to give them diuretics because their kidneys aren't working, so they're not going to be able to excrete it anyway. So there's usually a very fine balance with renal patients. Okay. All right. What questions do you have for fluid balance? None? I will say that if you have, you should have, there's this little graph right here that has your common IV solutions. If you want to jot down and take note, because I'm not going to expect you to memorize all of these, because a lot of them you won't ever see. But you are going to definitely want to know your half normal saline, so everything under the second block, so your saline solutions, your half normal, normal, 3% and 5% normal saline. You're going to want to know those. You also want to know that your lactated ringers is also an isotonic solution. And then you're going to want to know that your D5W is going to list it, like I said, as isotonic on here, but that's going to be considered a hypotonic solution because once it's metabolized, it's going to be hypotonic. And that should be all that you need to know. So you are going to want to know the tonicity. You're going to want to know examples of the fluid types and whether they're isotonic, hypertonic, or hypotonic. You're going to want to know if I have a patient that has hypotonic dehydration, what are you going to give? You're going to give a hypertonic solution, and you want to know an example of that solution. Okay.
So for the test, you want us to treat D5W as a hypotonic?
Correct. Yes. Everybody get that? All right.
Can I say the ones you just said again to make sure I got them?
Yep.
1/2 normal saline, 3% and 5% normal saline, LR and D5W.
Yes.
Okay.
Yep.
Thank
you know
you.
those, you should be good.
Okay.
And actually it tells you, I think it was it Narda that asked earlier about the lactated ringers? It actually will tell you on here exactly what is in that normal or in that LR. It's got sodium, potassium, calcium, and chloride. And then lactated ringers has some lactate in it. So it helps to provide some extra electrolytes where your normal saline doesn't. Okay.
Miss White.
Yes.
Where is this chart?
I put it somewhere on Blackboard. Let me see if I can find it. Hang on.
I think it's under the units somewhere down the bottom.
It is.
Yeah, it's under the fluid balance tab or whatever where the PowerPoint was.
I've been adding stuff pretty regularly to the bottom of this unit. All right, so actually, if you look under fluid balance, it says IV solutions chart. It should be that one.
Okay, thanks.
And there's one that says evaluation for fluid balance. It gives you some assessment findings for your dehydration and your fluid volume excess. Okay. The one that says IV fluids, do you know what's hanging and why? That's just kind of an FY, good read over. And just right before lecture, I took 2 photos that I uploaded that help. They're in a fancy book I've got, and they look kind of like that. And it helps to break down some assessment findings and your different types of solutions and what they're used for. Okay. All right, so it is 12 o'clock. We'll come back at 12 and we'll start on electrolytes if y'all don't have any other questions. Okay, start out by saying on each one of the slides when I talk about the beginning slide of each of the new electrolytes, it gives you your normal range. You will find different normal ranges in different various textbooks and sites and everything. I would just recommend for testing purposes to go with the ones that I do have on the slides. And I will tell you that when I'm asking test questions, I don't give you anything that's like just 1 point or 2 points off. I give you something that you can definitely look at it and say, oh yeah, that's not right. So I'm not trying to trip you up, so that if you're reviewing those numbers somewhere else and you see that they're a little off, they do vary from facility as well. I know Atrium's and Novant's normal results are like 1 or 2 tenths of a point off from each other. So don't panic about that. All right. So, all right, with our electrolytes, we have intracellular electrolytes or ions and extracellular. So your intracellular ions are going to be more concentrated or more predominant inside that cell. So your extracellular ions are going to be more concentrated on the outside of the cell. Okay. So some examples of your electrolytes that are inside the cells are going to be your potassium, your magnesium, and your phosphorus. And then predominantly outside the cell, you're going to see sodium, calcium, chloride, and bicarb. And for our testing purposes, we have taken away, I'm not going to discuss phosphorus, chloride, or bicarb. Yay, be very glad for that. All right. So we'll talk a second about how electrolytes move. So you have diffusion, and that's just the process that moves electrolytes from an area of higher concentration to an area of lower concentration. So that's how like your sodium moves in and out of the cell, depending upon its concentration and what issue's going on. So remember how I said that your water follows sodium. Depending on where your sodium has a higher concentration level, that water's following and moving behind it. Okay. Then active transport, this just occurs when electrolytes move across the concentration gradient. So it's basically moving in the opposite direction. And your sodium potassium pump is an example of this. So your sodium moves out of the cell as your potassium moves into the cell to help maintain a concentration balance. Okay. Then we have osmosis, where it's the process during which the water moves from an area that contains more water to an area with less water. And that's just kind of review. That's not on the test. And there's just a fancy picture kind of breaking that down, where you have your cell membrane, where you have more more ions up here inside or outside the cell, and then they just kind of pass over and move into inside the cell. So our electrolytes are super duper important, and our body requires very subtle changes to be corrected, and be corrected rather quickly. And this is so that we can maintain that homeostasis. So our body needs to maintain that fluid balance, so not be overhydrated or under hydrated, dehydrated, in order for those electrolytes to stay in that proper concentration so that they'll work properly. So our kidneys are going to be our primary organ that's going to regulate our fluid. So your kidneys are either going to excrete fluid or they're going to retain fluid, right? If you need fluid in your body, it's going to hold on to that fluid. If you have too much, it's going to get rid of it, okay? And do you remember how much I said that it's called obligatory urine output, how much you have to excrete and put out in order for your body to get rid of toxins and properly function?
30 milliliters.
Yes. 30 mLs. So if you have less than that, you have a problem and need to call the doctor. So that should be your minimum. It also serves purposes, your electrolytes, for muscle and nerve function. So if there's an imbalance in your electrolytes, proper functioning of your muscles and your nerves are not going to happen. These are lots of things in your body are not going to work properly, but your muscles and your nerves are going to be where you primarily see the most issues. And we'll talk about that and break that down a little bit more when we talk about the specific electrolytes. Okay. All right. I'm going to flip my. Okay. So our electrolytes, these are gained through our diet. So whatever we eat and drink, that is how we're going to get our electrolytes. And this is just an FYI here that your body does not store sodium, but it does store and hold on to potassium and calcium. Okay. So eating and drinking is how we find our sources of electrolytes. So the very first one I'm going to talk about is potassium. Potassium is the one where you're going to see the most issues from it, and it's going to be, I think, the most predominant electrolyte imbalance that you will see in your nursing career. Okay, so like this says, even very small changes in your potassium levels have an extremely profound effect on your body and are very poorly tolerated. And this is especially so with your heart. And I'm going to switch over to my whiteboard. Oops. All right, so with potassium. All right. So our normal range for potassium is going to be 3.5 to 5, and it's measured in milliequivalents per liter. Okay. All right. This is the most abundant inside the cell. I want a better whiteboard. I do not like this thing. All right. So like I said a second ago, very small changes in potassium are going to affect your different nerve and muscle functions. So some very vital functions that potassium has is it maintains or helps to maintain fluid balance within the cells. It helps to contract skeletal, cardiac, and smooth muscles. It also helps to break down carbs and fats. It helps to promote cellular growth. And it helps to maintain acid-base balance. Remember how I said the other day that in acidosis issues, you're going to see an elevated potassium, where if you have an alkalosis, you're going to have lower potassium levels. So we need an adequate dietary intake of potassium. Adequate dietary intake and adequate kidney excretion. To maintain your potassium balance. Okay. And remember I said just a second ago how that sodium-potassium pump, they kind of work opposite of each other. So potassium has what we call a reciprocal action of sodium. Meaning if you have a high potassium level, you're going to have a low sodium level. If you have a low potassium, you're going to have a high sodium. They're going to be the opposite. Okay. So if potassium helps contract skeletal, cardiac, and smooth muscles, you can see how this could be a very major issue in potassium imbalances on your heart. That's a huge issue you'll see. Okay. All right, so let's talk about hypokalemia.
Miss White.
Yes.
Please, can I see that for 1 second? Your board.
You
Your board, the last board. Can I see real quick?
I just erased it. What else? What did you need? What part?
After you said it needs adequate, I think the last part, like after the dietary intake and kidney excreting to maintain what?
Potassium balance.
Okay, thank you.
Yeah. So you've got to be taking in enough, and your kidneys have got to be working properly enough to get rid of potassium so that it's not building up. Okay. All right. So hypokalemia is going to be a potassium level less than 3.5. Okay. So anything less than 3.5. Your common causes of having low potassium level is something really easy: inadequate intake. So somebody not eating enough bananas. Inadequate PO intake. So whatever they're eating, they're not getting the right nutrients to maintain high enough potassium levels. Okay. Then we have different medications like our diuretics. So if you are given patients Lasix dose after Lasix dose after Lasix dose, and they're peeing a lot, anytime you do that, their potassium's going right out with that urine. Okay. So those are called loop diuretics. So that's going to be like your Lasix. They do make potassium sparing diuretics, but these are going to be your loop diuretics, like your Lasix. Use of corticosteroids can make you have low potassium levels. Also, digoxin. If I can spell it, digoxin. All right, so digoxin is going to help, or going to cause us to lose potassium. Also, laxatives and enemas are going to cause us to lose potassium. Any kind of GI fluid loss, so diarrhea or vomiting, or let's say NG tube suctioning. If we're removing those fluids from the body, anytime you remove a fluid from the body, potassium is going to go with it. Profuse sweating, like from heat exhaustion or heat stroke. Starvation, or being a prolonged MPO status. It's going to occur with people like that have anorexia and bulimia. Any kind of malnutrition. Your alkalosis. DKA, even though that's an acidosis, you're losing lots of urine. So you're going to lose urine. You're going to lose potassium with it. Dialysis. When you have a patient that's needing dialysis, their kidneys are not functioning properly. So if they're not able to urinate, their potassium levels are going to be up because they're not peeing that potassium out. So they have to get dialyzed or get dialysis. So if we over dialyze them and remove too much, then that can potentially make them have low potassium levels. Okay. And then that diabetes insipidus, where you're putting out that 30 liters a day of urine, where you're losing massive amounts of urine. Okay. All right. So those are our causes. Now our assessment. So what are we going to see in these patients that have a low potassium level? We're going to see shallow respirations. We're going to see anxiety and confusion. Some of these that are on the slides, I'm not going to type. They're going to have weakness. Remember, our muscles are not getting enough potassium to function, so we're going to have that muscle weakness and fatigue. you may very well see muscle cramps in your legs. How many people's grandma has said they've got muscle cramps in their legs and you need to go eat a banana? It's because you don't have enough potassium. So not that one banana is going to fix that, but that's the mentality of your grandparents thinking of, if I've got muscle cramps, I must have low potassium. I need to go eat a banana. You will also have heart arrhythmias. This is a huge one. Huge, huge one. Don't ever forget this one. So if you have potassium levels less than 3.5, your heart is very much at risk for going kooky. It's not getting what it needs, so it's going to be throwing off all these irregular rhythms. Okay, so these patients are definitely going to be on a heart monitor. Now, I will say that if you have a patient that has a 3.5 or a 3.3 potassium level, they're probably not going to see any cardiac effects.
Some folks have to mute their phones.
I'm doing it now. Okay. All right. So if you have a potassium level less than 2.5 milliequivalents per liter, this is a major medical emergency. Okay. You want to do something really quick right now, because anything less than that, your patient is at great risk for expiring. Okay, the heart cannot handle a potassium level less than 2.5, and your patient is most likely going to code. Okay. So I don't know about Novant, but I know a lot of times at Atrium, if that potassium level gets below 3 is when they'll put that cardiac monitor on. Between that 3 and 3.4, they'll kind of gauge the patient, but anybody that has a potassium of 2.5, they're going to be in critical care. They're going to be on heart monitors. They're doing bad. Okay. We want to get them help very quickly. Okay. So does everybody have that before I erase it? I'm going to clear that. All right. So let's look at our interventions. So how are we going to fix our patients that have a low potassium?
Potassium. And,
absolutely. So a quick, easy thing, if they have mild hypokalemia, so let's say that they are 3.5. Well, we're not going to get bent out of shape over a 3.5. So we might encourage them to eat foods that are high in potassium. So we might, and there's a little cheat sheet that I have hand out for y'all for foods that are high in different electrolytes. It's on Blackboard. So we're going to make sure that they have an adequate diet full of lots of potassium. So that's going to be like green vegetables, carrots, tomatoes, bananas, some milk and milk products, whole grains. There's a whole list. So we're going to encourage people to eat that. Okay, so adequate diet. Then we have our oral replacement therapy. Okay, so we're going to give KCl, which is potassium chloride. Okay, it's got a couple names. It's KCl, potassium chloride. They might call it K-Dur or Micro K. It's got several different names, but just potassium. Okay. Couple things with oral potassium. They are, they can come in capsules. They can come in these huge horse pills. With the capsules, most people can swallow those because capsules go down easier. If you have the kind of tablets, I will tell you to cut those in half. They get very, very jaggedy edges, which can sometimes make it harder for them to swallow, to have those jagged edges. So you can actually dissolve that tablet. They do not recommend crushing it, but you can like dissolve it in applesauce or pudding to make it easier for them to swallow. Okay. Potassium is usually like an extended release, so that's why you don't want to crush it. But they do say you can dissolve it. If you have to give liquid potassium, it does come in liquid form. If you have to give liquid potassium, you always want to dilute it. You want to put it in at least 4 ounces of fluid. It's very potent, very strong, so they recommend just putting that in some. I used to do that for somebody. I used to have the little cups in the hospital of grape juice. That was her favorite thing, was to dump her potassium, her liquid potassium, in grape juice. Okay. All right. Now, if our level is too low of potassium, or they are not able to take in oral solutions, because let's say they're vomiting and they're not able to keep this in, we're going to give it through their IV. Okay. And if you take absolutely nothing away from this entire lecture, please take this part from it. Okay. This is important. With, we'll call it parenteral replacement therapy. So that means anything that's not in the GI tract. Okay, so we're going to look at IV potassium. So IV potassium is extraordinarily potent and very dangerous. But at the same time, we give it every day. You want to run IV potassium very slowly. So for a couple of reasons. IV potassium is very, very, very irritating to your tissues. So even if you run IV potassium in an IV very slowly, it has a high probability of burning. I will always attempt to dilute IV potassium. So if they have, let's say, normal saline hanging, I'm going to try and run it concurrently or at the same time with that small bag of potassium to try and dilute it, because it does burn. Some patients can tolerate it, others cannot. Sometimes it takes me hours and hours and hours to get a bag of IV fluid in, because I have to slow it down so much because it burns that patient too much. With that said, it typically burns, it burns everybody. However, if it is not tolerable to that patient, or if you notice any kind of redness or swelling around that IV site, you want to stop that infusion immediately. Okay, it's very irritating to that tissue and can cause massive tissue destruction and damage. Okay.
So is a banana bag already diluted?
A banana bag is, but a banana bag has other stuff in it. Okay, so this is just going to be straight up plain potassium, and they come in usually little tiny bags, a little 50 ml bag. Okay. All right, So our infusion rate is 10 to 20 milliequivalents per liter over 1 hour. Now, if you talk to Miss Rumble in critical care, she will tell you that 10 is the maximum. However, in med-surg floors, they come in little 20 ml bags that we can give over an hour, okay? You do not want to infuse it any faster than that because you're going to cause your heart to go wonky and crazy, okay? So we want to run it at 10 to 20 an hour. Now this is usually a test question, and I want to make sure I'm clear on this so that people don't get goofed up, okay? Let's say we have a patient that has a potassium level of 3.2. The doctor is going to order typically to give 40 milliequivalents of IV potassium, okay? So we give only that 10 to 20. And remember I said that they came in 20 ml bag or 50 ml bags of 20 milliequivalents, okay? So we're going to run that 20 milliequivalents, that one bag, over an hour. Then since they ordered 40, after that one bag is done, I'm going to just immediately hang up the second bag so that they get a whole 40 milliequivalents. Okay. So when a doctor writes an order that says give 40 milliequivalents of potassium now or stat, that doesn't mean that you are going to right now infuse 40 milliequivalents. That means you're going to initiate that first 20 milliequivalent bag and then follow it up with a second one to give that total dose. Okay. I want to make sure that that's clear because I'm telling you that's going to be on the test. And I want to make sure that you understand that when it says give that now, I'm not wanting you to hang a 40 ml bag or 40 milliequivalent bag. You're going to do one back to back. Okay.
But you would give that over 2 hours?
Correct.
Okay.
Correct. All right. So I'm about to wrap this up, I promise. So never, ever, ever, and I mean ever, give potassium IV push. It is also not given sub-Q or IM. But if you were to give a patient IV push potassium, you are going to kill them. Okay? That is how they do lethal injection. They give you propofol and Versed, and then they give you a massive dose of IV push potassium, and that's what stops their heart. Okay? So never, ever, ever, ever give IV potassium. IV push. Okay? All right. And then our last intervention for that is just like I said earlier, and I think Crystal said something. We're going to have them on telemetry. Okay.
Like, can I ask you a question?
Yeah.
On the IV, what does the level have to be? Is it less than 3.2? Is that what you were saying?
It just kind of depends on the patient and the doctor. If you have a patient that has a 3.3, I may end up giving them tablets. It just depends on what they're able to tolerate and how it's going to be very patient specific.
Okay, it's like, okay, this level is a discretion against the doctor.
Yes. There are, at least at Atrium, we have what's called the potassium replacement protocol, where it gives us clear guidelines, and it'll say if the potassium is 3.3 to 3.5, give 20 milliequivalents PO. If it is below 3.0, give 40 milliequivalents IV, piggyback. And it also looks at their kidney function. So if they've got crappy kidney function and they've got a creatinine that's crazy, then that's going to change their dosage too. Okay, so there's not really a set, if it's this, I'm going to give PO versus IV. It's just going to kind of be at the discretion of a couple of different factors. Okay. Now, if it's 2.5, I'm absolutely going to give IV because we need to get something in them fast. I'm not going to wait for them to eat a whole bunch of bananas, and that one's just kind of common sense. So if you have that low potassium level, we're going to put them on cardiac monitoring or telemetry. Okay. And they'll do this on med-surg floors. It doesn't have to necessarily be a cardiac floor. That's what the purpose of telemetry is that you can read the heart monitors all over the hospital. But when you have an out of whack potassium, you definitely want to keep an eye on their heart rhythm, because too high or too low can definitely make you have some crazy rhythms. Okay. Any questions? None? All right. Well, we finished up a few minutes earlier. I'm not going to get into hyperkalemia. We'll save that for next week and finish up the other. Because I don't know that I can finish hyperkalemia in 10 minutes. So we won't even jump into that. Okay. So any other questions? No? All right. If nobody has any questions, we will call it a day then. All right. Y'all have a good one.
Thank you. You too.
Bye.
Thank you.